Hi, and welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Today on the show, we have Monique Rainford. She is an obstetrician gynecologist, and she wrote the Kevin MD article, "When it comes to bias, doctors need to do their homework." Monique, welcome to the show.
Thanks for having me here, Kevin. Very nice to be here. I wrote that article, and really what it's about, it's really causing us as doctors to examine our own implicit bias. And the key is that implicit bias we're unaware of and we can't access it through the conscious mind. So we could be very well meaning and think we have no implicit bias, no biases, but we could be wrong. And sometimes that's more dangerous, because if we think we have no biases and we think we have no implicit bias and no hidden biases, and we act as if we don't, but we really do have them, it really has been shown that we give worse care to, frankly, Black people because of these biases, and without trying to do the work to get to understand these biases better, that will continue.
Now, give us an example or a case study of implicit bias in healthcare settings that physicians, of course, may not be aware of.
So they did a study a few years back, and they looked at the treatment of acute coronary disease with thrombolytic therapy, and they found that Black patients did not receive the same level of care, or the correct care as white patients. And what is interesting, that was one study, but last year, 2020, this study came out in Florida, and it was kind of controversial because there was a lot of commentary when it came out. And it talked about the fact that if Black babies are cared for by a Black physician, their mortality rate is significantly better than cared for by a white physician. And when you look at this, who would really discriminate? Which doctor would really knowingly discriminate on the care of a baby? I don't think any doctor will. And so, to me, one of the explanations for something like this is implicit bias. If we're given less care because of biases that we're not aware of, it can impact the care and survival of people, babies right through to adulthood. And obviously very dangerous when you look at this study. And it's not to say that somebody has to be cared for by the person of their race, but the key thing is to make sure that we examine our biases, we do the work to find out if we have implicit bias, and we work to improve or eliminate those biases in how we take care of patients.
So when you say that we have to put in the work to see whether we have any implicit biases, what exactly can clinicians do?
So Harvard has an implicit association test, and that's a start. And you could do that test. I don't know the website by heart, but you could certainly Google it. And you could do that test and find out what kind of biases you have, like whether you're pro-white, pro-Black bias, for example, when we talk about race. And then after that, when you do that, you can do some research about how you can improve how you take care of patients, knowing whether, if you actually do have a bias or if that bias exists. Now, it's a little controversial in some ways because there's a lot of funding and a lot of energy going into implicit bias training. And there's some research that suggests it may not work. That being said, a few years back, there's a study that did some implicit bias training that was only 45 minutes. And when they examined it later, a few weeks later, they realized that the training works for people who care about their biases and want to do something about it. So I believe that any physician who really cares about examining if they have implicit bias and they want to do something about this implicit bias, they can do the work and they can make a difference in how they take care of all of their patients.
So when you go for training to fight implicit biases, so what are some typical things that they do? I'm just trying to imagine in a typical primary care setting. I'm a primary care internal medicine doctor. What are some things that I can do to check to see whether I have any implicit biases, and any techniques that I can do to stop it if I do?
Well, these are not certified techniques, but I can tell you that some practices that I found helpful in my personal practice is how I view the patient, different ways I view the patient. One way, like when I teach or share with medical students or staff, I might say, give the patient the kind of care that you would want your loved one to get, someone you love. In different settings, when I was more in a FQHC setting and I was talking to the general staff, I said, treat every patient like they're a VIP. Because sometimes it's just not about race, it's about accents, it's about culture, it's about religion, it's about dress. And so this bias, implicit bias even can come into care of all kinds of patients we take care of. And if we pay attention to how we're treating the patients or how we're viewing the patients, and instead of putting on the lens or the normal lens, put on a lens of, okay, I want this person to get the kind of care that I would want somebody that's very close to me to get. And I think that that could be helpful in how we apply or how we care for patients.
As you well know, the concept of implicit bias is heavily politicized in areas, of course, outside of healthcare. Now, whenever you talk about implicit biases in the healthcare setting, do you encounter any pushback against that concept?
It depends where you are. In the setting where I am now, no. I do think that where I am is embraced. I think they're actively trying to do a better job. But in real life, you know it exists. And the way I see it, or I've seen it throughout my life, is that you might say something to someone who may not get it, may not get that these biases exist, and then they say, no, it's not that. No, you're reading it wrong. No, you're misinterpreting it. So, like, for example, if a Black patient comes to, say, a non-Black doctor or any doctor for that matter, and they say, I feel I was treated that way because of my race, and the doctor tries to defend it or tell them, no, it's not because of it, that alone is dismissive and actually painful, because their doctor is telling them that their perceptions aren't valid, that their perceptions aren't important. And this is not to say whether the perception is quote unquote correct or not, but who determines whether it's correct is a patient's perception. And you don't have to agree with the perception, but just give them some validation. Most people want validation. And if you try to excuse it or dismiss it, the patient, I believe, will feel doubly assaulted. They have the assault of the action that happened, and they feel doubly assaulted. And then when you read a lot about what patients complain about, Black women, since I do a lot of work in health disparities and reading in health disparities, a lot of them say, I feel like they weren't heard. I feel like they weren't heard. So what does that mean? When you say something to your physician, is it that they dismiss you? They said, no, you don't know what you're talking about. They may not say it as bluntly, but if they don't respond and acknowledge what you're saying and acknowledge understanding and give some validation to what you're saying, then they'll feel like they're dismissed. And so I think we really have to pay attention to how we're responding to their patient, what kind of validation we're giving them. And this is not to say we agree with them, but just validating that we value their concerns, we value where they're coming from. And really, I believe expressing some empathy in how we do that, and then moving on to try to take care of them. And I think they will feel you're more of an ally than an adversary. I've actually seen that more in my practice when, for example, somebody doesn't want to get the vaccine. That's very controversial. And I hear their story, and somebody said recently, well, I don't want to get sick. And I said, I really understand, because what's true for me, I was concerned about getting sick from the vaccine itself, not so concerned not to take it, but I was really concerned about the side effects. But I explained from my situation, I recognized due to a personal situation where I had an exposure, someone in my home was exposed, I realized that the fear of getting the virus was way more than any fear I had of getting sick from getting vaccine. And clearly all the literature supports getting the vaccine. But I do believe that I saw a bit of a change in my patient when I shared that story. And it is shown, they've done research to show that sharing stories is very effective in how we approach our patients, and trying to be empathetic and help them to see that you hear where they're coming from, you respect their views.
We're talking to Monique Rainford. She's an obstetrician gynecologist, and she wrote the Kevin MD article. When it comes to bias, doctors need to do their homework. Monique, I didn't get a chance to ask you this earlier, but please share your story and journey to where you are today, and talk a little bit about the work that you've done with health disparities.
So my journey, I knew I wanted to be a doctor from about age 7. And then when I was early high school years, I thought, no, I'll do something else, all these career choices. And then I got back to medicine, frankly, because of a loss of someone very important to me, my favorite teacher and principal. And so I thought I was going to be actually a pediatrician, or I thought about pediatric cardiology. I thought about all these other different careers. And then when I assisted on a private delivery with the chairman of the department where I was at medical school, at the program I was at, that had a really big impact on me. And I went into OBGYN. I've been doing that for more than 20 years, but over the past 5 years in particular, since about 2016, I guess more than 5 years, I began reading and discovering much more about health disparities for African-American women and other Black women. It's actually something I noticed long before in medical school, based on a slide I saw in a presentation, but I didn't really get it. I didn't understand. And every time I asked questions early in my career and training, I heard poverty, poverty.
Mm-hmm.
And then within the last few years, I saw, no, not that can't play a factor, but that really is not it. And I began to understand a lot of the reasons why they exist. And so right now, because I believe in the care of women, because I believe in health and wellness for women, I don't think you can properly make all women healthy and well if you leave some women so far behind. And African-American women in America are really far behind in their health and wellness because of these, frankly, mostly racially based race discrimination disparities. And so what can I do to help that? And that's what I'm working on now in different areas.
So go into more detail. So you certainly talk about implicit biases, but from an individual clinician level, what are some of the things that we can do in the exam room to help narrow these health disparities you talk about?
I think we have to be even reviewing the care we give our patients and making sure that when we look at the care that we're giving our patients, are we giving them really the same standard of care, the same level of care? Are we missing out any details that we shouldn't? Are we missing out their routine preventative screening because we're so focused on the problem? Are we reminding them of that? Are we taking the time to say things that need to be said, or we're just avoiding it because we don't want any controversy? And I admit it's really difficult because right now medical visits are super short and there's a lot of pressure to see a lot of patients in a short time. I think organization helps. I think being really great on EMR helps because we do a lot of that. But I do think that we still, if we're in this career in medicine, if we're still delivering patient care, we still have a responsibility to try to make sure we're giving each and every patient the very best care that we can, regardless of their race or their circumstance.
And my final question, what's your take-home message that you want to leave with the Kevin MD audience?
We need to value all our patients, regardless of their race, ethnicity, sex, sexual orientation, religion, etc. And I think that we should try to find the good in all our patients, despite what we may believe. And frankly, try to give our patients the same level of care that we would want somebody we really love to get.
Monique, thank you so much for sharing your time and insight. And thanks again for being on the show.
You're very welcome. Thanks for having me.